Hi, welcome to another episode of the Mental Wellness Podcast. And today we're going to discuss an issue that is quite pervasive in our society. Globally, according to the WHO Mental Health Report 2022, 1 in 8 people worldwide live with a mental health condition. Anxiety, depression affects up to 700 million people globally. And of these, 90% are in low and middle income countries, and they do not get the support that they need. In our country, the Mental Health Task Force 2019 gave very damning statistics. Out of all outpatient visits, 25% are due to a mental health condition. Out of all inpatient admitted patients, 40% have a mental health condition. But it's common in our country to hear someone who's suffering from mental illness being called as either mwendawazimu, crazy, chizi. These terms look polite when they say it, or rather they look like very light terms. But to anyone who's living the mental health condition, to anyone who's taken care of someone who's living the mental health condition, and to anyone who's been affected directly, it's a significant barrier to seeking mental health care. I have a guest on the show, and the guest today is Dr. Tahir Kadernani, a psychiatrist and also a good friend. I'll let him introduce himself. Hi, Doc.
Hi, Dr. My name's Dr. Tahir Kadernani. Introduction to the public is as a psychiatrist. Introduction to you and to the people around you is as a younger brother.
Okay.
I think we've come from far, and it's a pleasure being here on this podcast. Congratulations first and foremost on having this and doing this. It's absolutely required. It's amazing that we're able to talk about mental health. It's creating a platform to break exactly what we want to discuss today. That's stigma. It's creating that platform of doing this. So kudos to you and many congratulations to you. And may this go on to be very, very successful.
Okay. Thank you very much. And thank you for gracing the invitation and taking time to actually come and talk to us about mental health stigma. Basically also to educate the society around us and create more awareness so that we can improve mental health outcomes in the country. Yeah, I think we can start off. So what exactly is stigma?
Stigma is let's look at a definition, and let's start by giving a definition to the word stigma, because I think that's the start of this whole topic. So stigma is having a negative mark or negative belief around a person, an institution, or a community, or a person's attributes. So it's that element of having that negative thought process or negative feeling around that person. And it is not limited to just having a feeling. It is now vocalizing it and taking actions towards it.
Okay.
So stigma is basically having a negative mark towards a person, his abilities, his insecurities.
Okay. And how? So now stigma, there's gender stigma, definitely. Then we also have, because we've had conditions like HIV and AIDS that also had their own stigma. And then now we are talking basically about mental health stigma. So I don't know, in your perspective as a psychiatrist, how do you think stigma is expressed in the Kenyan society, especially around mental health?
Okay. So I think in human nature, it's in towards any condition or any negative inclination towards something, which is basically what we're saying stigma is, we have a certain way that humans react. One of them is prejudice. Another one is discriminatory, right? So how it's coming out in the Kenyan system is, number one, people are afraid of employing, for example, someone with mental health. So there's prejudice there, right? Or they're discriminating people who have mental health, and they don't want to associate with people with mental health, isn't it?
Yeah.
So that is how it comes out. And that's just basic human nature. It is not something it's not also right to come out and say, yes, it is something wrong, but that's how we've been brought up. That's the society that we've been brought up in.
Okay.
So it's important to educate them on how to deal with, rather than just be very accusatory on their actions.
Yeah, and I think, but I agree with you that accusing, of course, people who are also not aware that it is actually stigma, because for the longest time possible, like for instance, in our setup in this part of the world, someone who's out of touch with reality, that is someone who's psychotic, who's seen walking around, talking to themselves or even laughing to themselves, will be like, this guy has lost his head. And such terms can be said, or mwendawazimu, you see. But then now, beyond that, there is the fact that sometimes this person, when they are treated and they're okay and they start raising certain issues, like even a family setup, very easily to be dismissed that they're not okay mentally, you see. And so that's part of what the expression also now gets into. I don't know what you...
I think that's what you call stereotyping, isn't it?
Yeah.
Because when someone has something, you've put a mark on them, and that's it, and that's how you continue seeing them.
Precisely.
There is no change in thought process of, no, he's better, or... And I think that concept comes in from the fact that we've never looked at mental illness as part of general illness.
Thank you.
Because if someone has a bacterial infection, they're treated, si amepona.
Yes.
Si anaendelea kazini, anapata sick of anaenda kazini, he goes back to work, and then that's normal.
Yeah.
He's not going to be asked, you had pneumonia yesterday, why do you have a cold today, or any of those questions, isn't it?
Yeah.
But when it comes to mental illness, it becomes a brand. You're branded.
Yeah, and with that point, I think you just brought me to one thing that I've been doing quite often is the look when you tell someone this is actually mental illness. They come to you, they have symptoms, they're struggling. You listen, and then you, of course, ask a few questions, and now you've gotten the symptoms, cluster the symptoms, and actually come up with a diagnosis. And you tell them it's a mental illness, and they look at you like, if it's a first time, and if it's someone who has a caregiver, the caregiver also looks at you like, so what I normally tell them is, wait, why is it that when you say it's a mental illness, I get this look? Now you educate and tell them, the body has different organs. We have a brain, we have a heart, we have a kidney. So I'm like, when you get a heart condition, you'd say that person has a heart condition. When the kidneys are failing, you'd say it's kidney failure. But I'm like, this is the brain. The brain, just like the heart and the kidneys, gets illnesses. They can be structural. Structural meaning it's a deformity in the brain, or maybe something has happened and in the structure of the brain that leads to an illness. It can be an infection. But then it can, now when all these are not present, once you've taken for different tests and you realize this is mental illness, people now look at it like it's not an illness. It's a different animal altogether. And that's why it's labeled differently, I think.
What you're saying just reminds me, just humor me. When we were in med school,
we
used to study together. What was your thought process around psychiatrists?
Well, I think what was interesting is psychiatry was this excluded specialty, right from undergraduate. And I think it's been propagated in society for so long. If someone had asked me 20 years back if I'd be doing psychiatry, I told them, perhaps yes, perhaps not, but not really something that I would have done. Even when I graduated first degree, I took time to actually think about psychiatry. It was the last thing in my mind, but then I eventually found my way and I was like, I'm going to do psychiatry. And that's how I ended up being a psychiatrist, yeah.
So in my whatever, I remember during med school and even before that, when the thought of psychiatry came, it was always about, to become a psychiatrist, you have to be mad kiasi. And it was the picture propagated by
society.
But not only society, but I think, I'll say our own colleagues had that whole element that they used to, a psychiatrist would come driving an old Mercedes-Benz, barely making it to the door of the hospital. And you would look and they would be dressed in a certain way and there'd be a perception around them. They created an aura or a perception around them. And it kind of influenced us, isn't it?
Okay.
And so for me, that was the case until looking deeper into it and understanding what mental health is. And I think during my undergrad is where I found a liking for this.
Okay.
And so that all of this is just a societal perception of what a psychiatrist is.
True.
And some people have played into that. The colleagues might not have been doing anything wrong. They might be living according to their own standards and they come out well dressed and all that. But because society has already created an image for you, that's the image you judge.
Okay.
The people as well, and that's what creates. That's basically how stigma also starts forming around these things.
I think around the same component of stereotyping, there's the aspect of language and what the spoken word, the power of the spoken word. Like, for instance, when someone says, that guy is crazy, huyu ni mwendawazimu, what is the impact and how does that now propagate stigma?
That's how the public views you, and that creates an element of also self-awareness around it, isn't it?
Yeah.
Mtu akikwambia wewe ni chizi, utacheka naye kidogo, lakini
deep down, your heart,
you're hurt.
Yeah.
And if it is repeated a number of times, becomes a norm, and then you start viewing yourself in that way as well, isn't it?
Yeah,
and I start withdrawing. It creates more of a vicious cycle.
And I think in the clinical setup is something I've seen quite often. A patient comes and you ask them, what are you being treated for? And the patient breaks down. And when they break down, you ask them, okay, I noticed this question made you quite emotional. Why would you? And they're like, but I've been called a mwendawazimu most of my life, or for most of what I've been experiencing. And it's really heartbreaking to see that is the impact of that word when said to someone, that repeatedly, as you said, over time, it gets into someone, and now they start looking at what they're struggling with and seeing themselves as deficient, as not someone who's fit to be in the society and actually live and work in the society.
Absolutely. But it's not only a word, right?
Yeah.
It's also how very close people to them engage with them. You reminded me of this when you're saying a patient, because we normally do corroborative history, isn't it?
Yeah.
And you're talking to the parents and all of that. And at times when you talk to the patient says, but naambiwa hii lazima niachane nayo, nisifanye hivyo.
Yeah.
Lakini hawanielewi, they don't understand me.
Yeah.
And that's, I think, the very core of the word is they don't understand me. Those statements are what tell us that how the conversations around this illness is happening in their home.
True. And now that creates another thing, that the immediate supportive environment becomes hostile to this patient and now contributes further to the propagation of the mental illness.
Exactly.
So you start dealing with now what we call social cultural factors around the patient, and now becomes the biggest hindrance again to treatment. Yeah. So do we have different types of stigma?
Yes, we do.
Okay.
There's public stigma.
Mm-hmm.
Yeah. Then there's structural stigma.
Mm-hmm.
And then there's stigma that involves the self.
Mm-hmm. Mm-hmm.
So public stigma is where we look at public institutions or public institutions which have their policies, and they create an element of negativity around the person. So, for example, not employing someone or creating a discriminative element. So he's having a mental illness. We need to let him go.
Mm-hmm. Mm-hmm.
So stuff like that.
Mm-hmm.
Then you have the structural stigma or societal stigma, basically, where the society now starts judging you as a whole.
Okay.
Huyu ni mwendawazimu.
Yes.
Tusimkaribie.
Okay.
He's in depression. If you're going to go near him with depression, you'll also get depression, like it's an infectious disease.
Okay.
Or he's having anxiety. It's going to pass to someone if you go close to him or something of that sort,
Okay.
The society starts judging you.
Okay.
Then you have the stigma that's associated to self, where now when you look at yourself in the mirror, because of all of this that has happened, you fall into the trap of believing what is happening is true. That mental health is wrong. It is being mentally unhealthy is a choice, and you've taken the wrong choice.
Okay.
And you start judging yourself there.
Okay.
So that is now when it comes and affects self.
Okay. Yeah, so I mean, across all these levels of stigma, I think beyond the structural and what do you call the societal one, there is the component of self-stigma. Most times, and I think you'd relate with me on this, you'd relate with this. So someone you know, maybe just someone's come to you and they explain to you their symptoms and all that, and you're like, what you're expressing is actually depression, for instance. And it has affected your functionality. Basically, you can't go to work. Socially, you've isolated yourself, you're withdrawn, and you need help. And the help means we need to treat you. And you're like, so I'll have to give you medicine. And bam, the self-stigma starts. You want to give me drugs because I'm crazy? How do you relate to that?
Absolutely. I think whichever patients we get to see, the first thing you're like, I don't want medication. They come to you and the first statement that comes across is, I don't want medication. And you're like, we have not even addressed what your problem is. We don't know anything about your problem, but there's such a negative attitude towards psychiatric treatment and medications. And I always tell them, let us first address the issue and then we can create a plan together. Mm-hmm. I think very importantly with a lot of these patients is we have to deal with their stigma. Yes. They're coming to us having fought off so much stigma, and all that they're worried about is if they go with medication, they're going to be judged further.
Yeah. So that's now self-stigma. Of course, also as a result of the societal and public and the structural one. And so it becomes a hindrance to good treatment outcomes already from the start. And even when a patient accepts take medication, it's very common to come back second time, third time, and still ask you the same question over and over. How long will I be on the medication? Why should I be taking this medication? I'll be dependent on the medication. and it's a very interesting concept because then now you start seeing that they've taken it because they had no other option. I mean, they accept they were struggling, and so now this is the only way out, and they start taking medication and they're feeling better, and they're like, the first thing is, when am I getting off?
When am I going to stop? Immediately, when do I stop it?
Yeah.
But isn't that's the fear that they have, isn't it? You look at it from this perspective, yeah. Mental health is still so unknown.
Yeah.
Mental health is still so unknown. Now imagine us as scientists and researchers. It's unknown to us. The person who is going through it, the first thing that comes to their head is, I'm the only one who has this.
Okay.
It is never like, say, when you have pneumonia and you think about, but the first thing you'll tell yourself is there's an outbreak. Mm-hmm. Yeah? It might not be true, but that's how you convince yourself there's an outbreak. So that's why I'm getting this. Isn't it?
Yeah, true.
But here, the first thing that they'll tell themselves is, I'm the only one. Mm. Now, already you've created an element whereby there is judgment from yourself, which you say it's self-stigma. Mm-hmm. And because you're judging yourself, even if no one else is judging you, there's already a thought that you're being judged.
Yeah.
Now, it is that fear that is causing them to follow up with these questions of when will I get off? How will I get off? All the stories around these meds is they are highly addictive. They have so many side effects. A lot of times, the patients may not have side effects, but they've read all this on Google and come and told you. How many times have you faced it? They've read on Google and come and told you, this is a side effect. I'm having this. And you have to deal with it.
Yeah. So that's something I've actually come across. It's I mean, for all of us, it's a common thing about side effects, and always go back. I think one of the things I normally tell my patients is, as a doctor, I do acknowledge that all these medications have side effects, but I have more knowledge than you, because if you read on the internet, you're just reading on the side effects. But I know that if you mention a specific side effect, maybe 5-10% of the population gets that side effect. And you read the side effects and you think it's all of them, but you could actually maybe get one or none at all, because bodies also respond differently to medication. I think that's something that now is a constant back and forth between us and the patient.
You know, the best thing is what? Is
Yeah.
how they Google. Can cough be a side effect of this drug?
Yeah.
And AI is going to tell them, and everything is going to be, yes, it can. You know,
Yeah.
because of the boxes that's written there, that this drug can have all these side effects. So that's how they Google.
Okay.
So it's like telling them with Panadol. I give them the example of Panadol. I'm like, how often do you take Panadol? They're like, Panadol. I'm like, have you ever read the box to see what potential side effects can be on Panadol?
Yeah.
And they go like, no. I'm like, you should.
Yeah.
Because
true.
if you're going to Google the side effects, Panadol can give you the similar side effects as many other drugs.
But I think because our medication, one is medication that is highly controlled. You cannot go over the counter and get this medication. You need a prescription that is stamped for you to get the medication. So, as you rightfully said previously, when you're talking about the aura created by the psychiatrist coming in, is the same around the medication. I think that aura now comes
it comes to the drug as
medication,
well, man.
this class of drugs basically.
He has taken this drug, that's why he looks like this.
Yeah. So there's that component of it, yeah. So just to even take it further, how is all this stigma now propagated? If we were to look at it, apart from the self-stigma, like in the societies, in workplaces, in families, in the community, how is it commonly propagated?
So, one, I think something that we look at is media.
Mm-hmm.
So when you have media doing that to certain cases and propagating it as because of mental health issues, this XYZ happened, and you create a whole aura around it. Number two, cultural beliefs.
Yeah.
I think that's the biggest one, because it's our society. We have 42 communities in Kenya?
I think at 45 currently.
Yeah, 44, 45.
Yeah.
And all of them have their own
Cultural
beliefs and
practices.
thought processes around different things, especially mental health. Sana sana utasikia waganga, right? If you go towards religion, and it's not saying, I think it's important for us to just mention that we're not saying religion is wrong or there's not practices around the religion that would affect, or wagangas are not doing what they're doing, what they're supposed to do. But there's an element of confusing what can happen there with mental illnesses. So those two would be some of the ways of
propagation of stigma.
Stigma.
I think on the religion one is actually very interesting, because when these symptoms present, the first call for most of the religions is either the church, the mosque, or in other traditions and other religions, it's a spiritual thing.
It's a spiritual thing.
Yeah. So and I think that the thing that needs to come out, and I think from what we do, is that spirituality has its own protective factor in mental illnesses, because it creates a sense of community and sense of social connectedness.
Absolutely.
But in the sense that people resort to explain the symptoms that they are seeing in this person that are clearly mental illnesses to either being bewitched, to possession, and so we took them to the church or to the mosque for prayers that then now they're exorcised. I think that's a common thing, and I know both you and I and many other psychiatrists in the country have seen a patient who they've gone all the way through the spiritual way and finally decided, let's come to see a doctor so that we can see if we get some help,
But you see, that is where I think we need to bridge the gap.
Mm-hmm.
Because we as psychiatrists need to reach out to these leaders.
Mm-hmm.
These religious leaders, and be able to have conversation with our mosques, our nearby mosques, our community centers, because at the end of the day, it is this patient who is suffering. They have belief in prayers, and that's a very important part of their society and part of their culture and thought process. We need to be able to incorporate that bit we need to be able to incorporate that bit, and also at that time seek the right professional help. It can be a two-pronged fork. It does not have to be either this or that.
Yeah.
And this is where this is the trap a lot of religious leaders fall into. I have had many cases where someone is undergoing depression and they believe that their faith will heal them. We have not put them on any medication, but we have just tried to do therapy with them, psychotherapy, and reinforce their belief in their religion, and it has worked because their strength in their faith is that strong. So we're not fighting them, but that thought process has to come out to those leaders. Religious leaders at times feel that we as scientists or psychiatrists are fighting them in terms of what is happening.
Yeah, so I like the point on bridging the gap, and I think there's already in our country, there's significant steps being made. I think just recently we saw where one of the major mental health institutions in the country launched a mental health self-help book with the clergy. And I think that's a very, very, very bold step, and to try and bridge that gap and create that integration that what we are all on the same side. You tend to become the first call because socially and culturally, people believe it's those other causes as opposed to medical illnesses. And then at some point, you now come to us. And so I think that's a big step in the country already. Very, very commendable. I think now the onus is on all of us in this space of mental health as practitioners to now take it up and now spread that across all the religions.
All the religions, I think.
So that's why we have that back. And then the other thing is actually map out communities and the influential people in the communities that then now become our, the pathway in which we get to the community. I mean, there's a lot of work when it comes to, if I just listening to you, I was like, there's a lot that we need to do beyond the clinical setup. Because the clinical setup, we're seated somewhere, just coming in. Of course, there are many. There are quite a number of cases, but then I think at some point we have to also now the community psychiatry component.
Yes.
Actively now start engaging
communities
communities on that too.
And exactly as you put it, the influential, I understand we cannot reach everyone, but we can engage the influential people. It's something that we in Mathare, at MNTRH, we've been talking about and trying to take active steps towards, meaning trying to reach the important people in those communities so that they start having a knowledge around mental health and mental illnesses, and then they can help us. From a selfish perspective, it is because of trying to decongest an already full hospital.
Okay.
But in the bigger picture, it is all about educating that community about mental illness.
Yeah, that's true. And I think that is the biggest public
facility,
mental health facility in the country.
That's in East and Central
Africa, you see. And so just mentioning Madara is something that already now...
It's a fear factor.
Precisely. I mean, most people will tell you, so you got that point that you had to go to Madara. I mean, you'd also get a patient who's like, I was so bad. So it's the picture created out there is that by the time you get there, boss, you were really sick. And I think now with these such conversations, and I think the hospital has already taken already bold steps.
The hospital is changing. It has started creating. We've started working on a public image, on social media, on reaching out to communities, being able to talk to communities. As a personal initiative, when I was in the ward, I invited the families. We had a small mini conference with them about their conditions, just so that we start educating these communities on how to deal with it.
Okay. So one thing about mental illnesses is that it causes what we call social occupational dysfunction. And occupational here meaning if someone is already of adult age and they're working, then it means occupation is they're working. If someone is still in college or school, that is primary, secondary, they're going to school. And so that's that's actually their occupation. So stigma around the workplace.
It's massive.
Yeah, I think I'd like to hear what you'd like to say about that.
It's massive. How many times have you got a patient coming to you, and when you're saying you have to write a sick off, they say, "Do not mention that we've come for mental health issues. Please don't mention we've come for mental health issues. Write something else on their sick offs or anything of that sort." And because the perception is that if you have a mental health condition, very soon you're going to be let off.
Okay.
You can get let off. So I think it's a big thing that needs to change, and that's where I work as a coach. I work as a performance coach, and the aim around this is to work with. And I've been working with company executives and directors and HRs in trying to show them that mental health is a key component in how people perform. Burnout is real.
Yeah.
Chronic fatigue is real.
Yeah, sure.
And not everyone, just because they say they have a mental health issue, is schizophrenia, bipolar, and all of that. And even those that are on schizophrenia, bipolar, if they're on the right medication, they're very able to work and perform. So why should we then, how can we change the mindset towards them? What can we do to help them is what performance is then all about.
Yeah. So how do you think we can reduce the stigma in the society?
Reducing the stigma in the society?
Yeah.
This is number one, being able to talk about it.
Yeah.
Freely talk about it.
Yeah.
Number two, what we already said, engaging the community. Being able to engage the community from a profession, as a profession.
Yeah.
And also, I think as a government, they have the Mental Health Act, which was revised in 2022,
Yeah, sure.
is doing a lot of good work around the element of stigma, the fact that it
Actually entrenched in law.
It integrated general health and mental health as one.
Yeah.
And that's a big step towards bridging the stigma. So you can go to a facility and any facility in Kenya and be looked at in terms of your mental health as well.
Okay. Yeah, and I think beyond that is to also get people who are confident and comfortable talking about their struggles with mental illnesses out there, because then now it makes people actually accept that.
Lived experience.
Yeah, lived experience is one thing that I think we also need to work on to make sure people get to accept that it's a normal condition. It's okay. Just like any other illness. Yeah. And no one chooses illness in this world. Illnesses just come to us, and you don't know when you're going to be sick, what you're going to be sick with, and that's part of life, yeah?
Absolutely.
Yeah, and so I think, what is your message for people living with mental illnesses, for caregivers, and for the general public when it comes to stigma?
For those living with mental illnesses, you're not alone.
Yeah.
Like we said, 1 in every 4 suffers from a mental illness in Kenya. So you're not alone. Look at when you look at your family of 4, 1 is going to have it. And you look at 8, you'll be 2.
Yeah.
Those are the statistics.
Yeah.
And realizing you're not alone means that you're able to talk to someone about it.
Okay.
Isn't it? Being able to, for the caregivers, again, seek help, talk. Don't feel that you're the only one living this life.
Yeah.
Make time for yourself. As a caregiver, make sure you're giving yourself priority. You cannot give when your cup is when your cup is empty.
Yeah.
So make sure you're doing, you're practicing general good health for yourself in terms of physical and mental.
Okay.
And for the society, I think keep engaging in talks around this from community level to a national level. I think as a country, we're doing a lot on it. Having these conferences around mental health. and celebrating Mental Health Day and all of that.
Yeah.
So we're doing a lot on it, but still there's space for more.
There's
So we
space
need
for more.
we need to keep pushing. We need to push those barriers a lot more.
Yeah. And I think that's I totally agree with you that there's a lot to be done when it comes to handling stigma in the society, and that to just improve health-seeking behavior around mental health conditions, and in regard to that, also now improve treatment outcomes and reduce the burden of mental illnesses in the country. So just to conclude, what do you think we can do to prevent?
Prevention.
Yeah, of stigma.
Prevention of stigma is, again, we'll repeat the same things. Talk.
Yeah.
Let's talk mental health. Let's make it a common topic.
Yeah.
I think parents should talk to their children about it, bring it up in schools, have a subject on psychology and mental health in schools.
Yeah.
From the time they enter secondary school, Form 1, Form 2 should be someplace where they're able to understand this.
And I agree with you on the school factor, because 50 to 75% of mental illnesses actually begin in that adolescent period.
Absolutely.
And so they start struggling, of course, with adolescence, the biology that happens, the neuroplasticity in the brain, how the brain changes that are happening, biological changes, and now mental illnesses also set in. And so oftentimes you'd see parents struggling with what's happening with my child. You know, there's this behavior I've noticed, there's this, and then they come, you do an assessment, you have everything, and then now. So I think, I agree with you that we need to target schools. And
even workplaces.
And workplaces, yeah.
I think, if I'm not mistaken, in the Kenyan law now, it requires...
The Mental Health Act 2022, actually. It captured all that,
in the workplace.
Yeah.
Schools is still... you still have a gap because not every school in Kenya has a counselor.
Yeah.
So that's something that we should look forward to.
Yeah, I agree.
Every school in Kenya should have a practicing psychologist or a counselor to be able to talk about mental health.
Okay. Yeah. So it's been a great discussion, and thanks for coming to the show and shedding more light on stigma in mental health care. And I think such discussions are discussions that we look forward to. We hope to having you back on the show to discuss further on any other mental health condition or
Appreciate this, Asante Sana, and may this go on to be the channel which helps break the stigma.
Yeah, so of course that was the whole objective, that we improve the mental health literacy levels in the country, educate and create awareness, and also reduce the stigma. And I do hope that we'll actually be able to do something stepwise, slow by slow, but we get there.
Absolutely.
Yeah.
Absolutely. I think this is brilliant.
Yeah.
Brilliant work,
Yeah.
Tahir.
Thank you very much. Yeah, so this has been another episode of the Mental Wellness Podcast. Today we discussed about mental health stigma. It's been quite an insightful discussion. I do believe that you have learned something about stigma and how it's propagated in the society and how we can actually prevent stigma in the society. I also do believe that it has opened your minds and opened your thought process around how not to propagate stigma in the society. We look forward to further discussions on this and even unpacking mental health illnesses in other shows. It's been very insightful, and thank you, Dr. Tahir Kadernani, for actually gracing the podcast and sharing your knowledge and expertise on this. Don't forget to like, subscribe, and share this. The link is in the bio. You can follow us for more insightful discussions on mental wellness in the country.